Welcome everyone for NCOR Evidence Summary webinar. In this session, tonight is going to be Dr. Daniel Bailey and myself who will be presenting two different papers. The webinar should be around 1 hour long, and there should be time for Q&A after each presentation. And the aim is really to try to merge a bit of clinically relevant information that you can use in practice or in your teaching with your students, and also trying to see, to try to help us to develop some critical skills regarding articles and what to look for and some, pitfalls that might exist. Great. Okay, so my presentation is going to be about a systematic review and meta-analysis that we published end of last year, which looked at the effectiveness of manual therapy and exercise therapy on headache intensity and frequency for patients who live with cervicogenic headaches. So first, I'm going to talk a little bit about the topic, and then we'll go a bit more in details about that paper. So you might be familiar with the ICHD-3, which is the International Classification for Headache, and that's the third version of it. And the ICHD-3 is divided into 4 sections. So there are the primary headaches, secondary headaches, neuropathies and facial pains and other headaches. And at the end, there's an appendix with even more information. It's a very thorough document, very useful, but it can be a little bit difficult to digest and read sometimes. So in primary care, patients who come to visit us, any healthcare practitioners, that's not just osteopaths, that's the most common headaches we tend to see. So the most common one are tension type headaches, then migraines and tension type headaches combined. Secondary headaches, other secondary headaches, it's 7%, so it's a bit less frequent than medication overuse headache, which is probably a diagnosis that is often missed. 6% other type of headache, 5%, and then cluster headache, 4%. And there's quite a lot of work done by OPHM, which I will talk about later, to try to sensibilize a bit more osteopaths and other healthcare practitioners about cluster headaches to become a bit more aware of that, quite debilitating condition. I see the message about the echo. I think it's because you might have joined twice, so you might need to log off of one of the 2 devices or one of the 2 windows that you have. In the UK, for osteopaths, we have 9% of patients who come every day who present with headache. It doesn't mean that it's the symptoms for which they visit their osteopaths, but it's part of their presentation. They will have some form of headache. So it's definitely something quite common that we see in practice, patients with headaches. So in this session, we're going to look at one specific type of headache, which is part of the secondary headache. So it's really, if you think about the tree of the classification, we're quite lower down into that classification. In the secondary headaches, there are quite a few of them. And the one we're going to be looking at are the number 11, which is headache or facial pain attributed to disorder of the cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other facial or cervical structure. And within that, then you have subdivisions, including cervicogenic headaches. And as already said, so secondary headaches is around 30% of what we see in primary care. So they are not extremely common secondary headaches, fortunately for the patients. The definition of cervicogenic headaches are headache caused by a disorder of the cervical spine and its component bony, disc, and or soft tissue elements, usually but not invariably accompanied by neck pain. And this is something that is likely to potentially be a slightly overdiagnosed in clinical practice, because it's something we might feel having tools to support patients who have cervicogenic headache, because we can work on the neck, we can do some manual therapy, we can maybe do some provide exercises and advice. But we have to remember it's not that common. it's 1 to 4% of patients with headaches who will have some form of cervicogenic headaches. So I mentioned about the ICHD3 having a very thorough detail of the definition and the diagnostic criteria, and that's the ones for cervicogenic headaches. I quite like the first one, which is the first item is that it's any headache fulfilling criterion C. So I found that very, administrative the way it's organized, but anyhow. And so there needs to be some form of evidence, either clinical or imaging. So we don't need the imaging for us to be able to have this diagnosis, obviously, but of some form of disorder or lesion within the cervical spine and soft tissues, which seem to be attributed to the headache. And we will see that there is a test that is used that is very useful in practice for that. And in this criterion C, what we see is that there should be a temporal relation between headache and neck pain. So it sort of makes sense when the patient describes the neck pain that it happened after or during neck pain and so forth. And that if one improves, the other one would improve. So there seems to be a sort of temporal profile that fits between the neck and the headache. And often we would also have cervical range of motion, which would be reduced, and that neck movement would make the headache worse. And the last one is something that we wouldn't have access in our own practice, which would be headache abolished following diagnostic blockade of a cervical structure or its nerve supply. And obviously, we can have these diagnoses as long as there's not another diagnosis in the ICHD3, which would fit better the patient's presentation. But one thing we have to remember, which is maybe where there's a slight risk of overdiagnosing cervicogenic headache, is that neck pain is very common in many forms of headache. I really like this infographic that was done for the Migraine World Summit, where they describe the 4 phases of a migraine attack. And as you can see in the early sign of a migraine, neck pain can be one of these symptoms. And that can lead patients saying, first I had neck pain and then I started developing a headache. So I think it's coming from my neck, which really makes sense. It's really logical to think that way. But it can just be the prodrome phase of a migraine. So being able to differentiate quite clearly between cervicogenic and migraine is quite important because management would be very different. Neck pain has this sort of is a diagnostic overlap. It's very common in migraines. Nearly 3/4 of patients with migraines will have neck pain. Tension type headache. Nearly 90% of patients with tension type headache will have migraine, and patients who have a mix of migraine and tension type headache, again, a very high proportion of them will have some form of neck pain. So 80%, is a firm rule of where that these sort of headaches have neck pain often associated. So it's not just cervicogenic headache that will have neck pain associated to it. In this infographic, it reminds us of the sort of main clinical features that we would have between cervicogenic migraine and tension type headache, where the ratio female male might differ. In cervicogenic headache, it would usually be just one side and always the same side, because if you think about one structure in the neck that may be at the origin of the problem, that structure is on one side and will stay on that side. When migraine can change side, and tension type headache obviously is bilateral. The location can be different, and I think one thing that is quite interesting to remember is the duration of these. Cervicogenic, we're looking at, it could be quite brief, like 1 hour, but it can be quite long too. It can be to several weeks. A migraine, as you probably know, is between 4 to 72 hours. That's a fairly standard definition of migraine. And tension type headache is between days and weeks. And then there are also differences about pain character, the triggers and the associated symptoms that can happen during that. So I mentioned a test that is quite useful for assessing whether a patient might have cervicogenic headache. It's the cervical flexion rotation test. If you've never done it, it's a very simple and easy test to do in practice. To do that, the patient is supine, and we are going to passively fully flex their upper C-spine. And then we're going to rotate the patient's head on both sides until the end of range. On a normal, on an asymptomatic patient, we would expect roughly 44 degrees, but if you think about 90 degrees, you would be roughly at the middle of that. You would expect to have 44 degrees on each side. And the test is positive if the range of movement is less than 33 degrees. So again, if you think about your quadrants, that would be a third of that roughly. Or if you notice a decrease of 10 degrees, and that would be if you compare right and left. So that's something that would be fairly, easy to assess. And that test has, good sensitivity and specificity. I've just, put here reminding us what sensitivity and specificity are for. The sensitivity is the ability to test correctly patients with a disease. So here, we have 78% of chance of testing a patient who has the disease and for the test to be positive. When the specificity is basically the other side of the coin, is the ability of a test to correctly identify people without the disease. I.e., if the test is negative, it's 85% chance that the patient does not have cervicogenic headache. So it's quite rare for us to have tests in, clinical tests that are quite sensitive and specific. So that's quite a useful test to use in clinic when we suspect cervicogenic headache. So moving on to the management of patients with cervicogenic headache. This was a final year student at the UCO, Pietro Bini, who did his dissertation on the topic, and he did a systematic review, and then with further support from the rest of the team listed below, we updated the systematic review and we ran a few meta-analyses that I will present to you. So we found 20 studies that were included, and 6 of them were we were able to include them in the meta-analysis. So in total, there were a bit more than 1,400 patients if you amalgamate all the sort of participants in the different studies. And the trials that were included were testing lots of different interventions. Most of them tested HVTs, but quite a few of them combined manual and exercises. And then, as we can see going down, there were less and less of them looking at exercise alone, trigger point, articulation, kinesiotaping, dry needling. The ones that looked at exercises, most of them were looking at doing exercises and or rehab around the scapulothoracic area or craniocervical area. So that were the main 2 areas of the body that were targeted in these trials. So I'm going to present you quite a few forest plots, and I thought maybe just a bit of a recap about what we're looking at when we look at that would be useful. So in the middle, you have this vertical line, which is the line of null effect. So if you had a study that found no effect at all of intervention and or placebo, that there was no difference at all between the 2, then you would be exactly on that line in the middle. Then that line, the horizontal line, which is now blue, is to give us a sense of the effect size. So how much effect did that provide? And if it favored the intervention in the experimental group, that would be on that side, on the left side of the diagram. And if it favored the sham or placebo group, it would be on the right side of the diagram. Then the little squares, which are green on that one, they're not always green, but it doesn't really matter. That's the result of that specific study. So it tells you which effect size it found. And the smaller the square is, the bigger the sample was. So it's quite a good sign when the square is small. it should be the opposite. Sorry, that's wrong. The smaller the square is, the smaller the sample was. And then you have the line, which is the confidence interval of the results. And again, the shorter that line is, the bigger the sample is. So if you think about the power of a study, if you have loads and loads and loads of patients, you're much more likely to have a true finding, what is likely to be true, rather than, you know, a false positive or a false negative. So the certainty of your results are likely to be better, and therefore your confidence interval is going to be narrower. So in that one, we can anticipate that it was a small sample size. So, and that's why I got that wrong with the square, sorry. And that's why the confidence interval is very wide, because we're not really sure. Probably we didn't have enough participants in that study to be sure. And probably the most important aspect is this lozenge, I don't know how to pronounce this word, sorry, at the bottom, which is black usually. And that gives us the combined points of estimate, so the combined little squares like this, and that is if you draw a line, a vertical line, that will be where the effect size is. So here we will be around, I don't know, 1.3 maybe, or something like that. And the horizontal line is the combined confidence intervals. So when we are looking at that, we are looking, is it favoring the experimental? Yes, it is, which is good. Is it crossing the line of null effect? No, it isn't. So that gives us a bit more confidence that there might be some true effect of that intervention. And then how large is the lozenge? The larger, the less sure we are in the results. Okay, so now that we have this little recap, we can look at what we found. So when manual therapy was compared with control manual therapy, so some sort of sham manual therapy sort of treatment, looking at headache intensity in the short term, it looks like there is, you know, effect size in favor of doing this. Then we did the same, but we only included studies that had a low risk of bias in when we were rating them. And when we do that, as you can see, this lozenge is becoming a bit narrower because the confidence interval is smaller, because we have more certainty, because the quality, probably the studies had more participants, which often goes with the risk of bias. But also we are becoming quite closer to the vertical line, so that the effect size is becoming smaller. So the more we remove trials of poor quality, the less effect size we notice for headache intensity. If we do the same for intensity, but long term, which is often what patients might be interested about, you know, how will I be after the session and how will I be in 3, 6 or 12 months time? Here it was anything above 3 months. Again, we noticed that when including all of the different studies, the effect size is fairly moderate, but existing. And if we do the same with just the low risk of bias studies, we find exactly the same finding. So it doesn't change at all the meta-analysis results. When we look at the frequency of episodes of cervicogenic headaches and whether manual therapy was helpful or not, you might notice how wide this lozenge is. So again, there might be a bit of an issue here with some studies having, you know, maybe not big samples, and therefore we're not really sure, and the confidence interval is quite big. So if we do the same, but we only use low risk of bias studies, we have a much less wider lozenge, and the effect size is not very big at all, but it's still in favor of the experimental group. If we look at frequency of cervicogenics, but long term, again, we have a small effect size, fairly good confidence interval, it's not too wide. And if we do the same with just the low risk of bias, we have exactly the same sort of forest plot. So that's pretty good. And finally, if we look at disability short term, you might notice that there seems to be one big study that had loads of patients, well, in fact, when I say lots here, we have here the number of patients included 60, but the others have tiny little squares and very long lines, including 2 of them that cross the line. So it's not very positive, optimistic, and another one which is a tiny square, very long line, but doesn't cross the line. So for that one, if we remove the one with high risk of bias, it doesn't really change much the overall effect, which is small but existing. So if we try to summarize what that means, what can we get out of that? We have found that both manual therapy and exercise, they do decrease intensity frequency in short and long-term disability. The effect size is probably not very high, but it's existing. The risk of bias in most trials was very high, and that is something that is, obviously problematic and that needs to be changed. So we are at a stage where we have probably enough studies at the moment to do a meta-analysis, but probably we should not do other meta-analyses or systematic review, but we should start doing more clinical trials on that topic to be able to provide better quality evidence. And what we found when we looked just at the low risk of bias trials, there was moderate quality evidence in favor of HVT compared to placebos. If you remember what we said at the beginning, most of the studies assessed HVTs. So it might be just because of that we found favor mostly of HVTs, because that's what had been the most tested, or maybe because there is a real signal that HVT is supporting patients with cervicogenic headaches. I mentioned the OPHM team. So OPHM stands for Osteopaths for the Prevention of Headache and Migraine. I think it's something along those lines. I'm not really sure about the acronym. I'm not part of OPHM, but the 5 others are the members of OPHM, and they got a grant from the Osteopathic Foundation, and I worked with them to develop the headache project, which was education and assessment for competence in headaches. Part of that was to assess the knowledge of osteopaths in the UK and to understand a bit what they knew about headaches and migraines. And that was published last year. So if you want more information, you can download the paper from the iJob. And following that, we developed an e-learning program, which was quite thorough and really trying to, based on what osteopaths knew and knew a bit less, trying to really fill the gaps in their knowledge and skills. And that we tested that in a randomized controlled trial, which was completed last year, and we are hoping to submit the manuscript in the next few weeks. We're nearly there. So that's it for me. Please feel free to join us on our socials to get all our updates.
This is a paper that was recently published on cognitive functional therapy, or CFT. It's one of the authors is a physiotherapist from Australia called Peter O'Sullivan, who's fairly well known, and I followed him for quite a long time. Find his work quite interesting. He was one of the sort of authors who originally published back in the 90s about the importance of core stability and how critical this was. Well, that's perhaps a bit unfair, but he identified changes in the function of the muscles of the core stabilizers, transversus abdominis and internal obliques, and he identified how people with back pain have different functioning core stability muscles, and this was potentially slightly incorrectly interpreted as being a cause of the back pain, and that sort of led to this movement of everyone needs to strengthen their core stabilizer muscles to fix their back pain. And he was partly within that camp, I think, but he's really sort of changed his approach to back pain since then, and has been advocating this cognitive functional therapy approach. And so this is the first large trial of that approach. So this was a 3-arm trial where they looked at CFT and then CFT where they used biofeedback devices on the patients, and then they compared those 2 interventions to standard care. So I'm just going to go through the paper step by step, a little bit like how I went through it the first time I read it, and just the sort of questions I was asking, and then the sort of things I had to look up and refresh myself to interpret, particularly with the statistical analysis aspect of it. Okay, so this is the abstract. The link to the paper was on the first page, but which you'll be able to get hold of when we share the slides. But I'll just run through the abstract. You don't need to be able to read it because I appreciate it probably looks quite small. So the low back pain is the leading cause of years lived with a disability. Now, years lived with a disability is a metric that was used for the Global Burdensome of Disease study, which was a really interesting study. It was an enormous study, one of the biggest studies ever conducted, so large that Bill Gates had to fund it. That's how large it was. And it looked at the incidence and prevalence of diseases globally. And it included musculoskeletal diseases as well as things like respiratory diseases, cardiovascular diseases, and cancer. But as well as just evaluating mortality, so how quickly does the disease kill you, it also looked at how long do you live with your disease while it's causing you some form of disability. So this meant we could start to compare non-fatal diseases with diseases with high mortality by comparing the level of disability they cause rather than just the years of life that they take away from you. So that will be years of life lost versus years of life lived with a disability. So it meant we just had a new way of comparing the burdensome of disease, which is why it was called the Burdensome of Disease study. So that's a good one to look at if you're interested in big data. So this is a randomized controlled 3-arm parallel group phase 3 trial. So randomized as in participants were randomized to the 3 different groups. It was controlled for as many potential biases and variables as possible. It was 3 arms, so we had 2 with CFT, one of which had these biosensors, and then one was normal care. And it was a phase 3 trial, so it's where we're comparing the intervention against standard care. So in principle, CFT targets pain-related cognitions or pain-related thoughts that the patient has, emotions that they have that are attached to their pain, and behaviors that they perhaps exhibit as a consequence of their pain. There were quite a few exclusion criteria in this study, which I'll go through in a little bit more detail. And yeah, I'll go through what normal care was as well, because that's a really important question. Thank you. So the primary outcomes for this study were activity limitation. So how disabled were the individuals pre and post treatment, and that was measured with the Roland Morris questionnaire. And then quality of life quality of life years, and this was measured with the EQ5D. So this was looking at how many years of disability-free life did these individuals have. And they used that to assess the economic impact of the intervention, so that the financial impact versus the physical limitation impact. In summary, they found that patients needed 7 treatments over 12 weeks, and then they had a booster treatment at 26 weeks. That was kind of the average intervention that patients received. And they found that the interventions in both groups, so the CFT and CFT with biofeedback, was more effective than usual care for activity limitation at the 13-week point, although not the 1-year point, and the mean difference, which I'll go into a little bit later on. So that was everything that came up in the abstract, and so you get a flavour for it, but there's quite a lot of detail there that needs unpacking, and so that's what I'm going to try and do in the rest of the presentation. This is the Global Burdensome of Disease study. I think one of the best things about it is the way it's been visualised on the Health Data website, the links there. So, for example, this image that you can see now compares the most burdensome diseases in 1990 compared to the most burdensome diseases in 2019. And this is rating them according to the years lived with a disability. So if you're using mortality as your metric, you would have a different ordering here. But because we're looking at years lived with disability, this is what we end up with. And this is globally for all sexes, all ages. But But what you can do is you can really drill down into different age categories, different sexes, different locations. So this is the West Midlands where I live. This is all ages and this is both sexes. And this is going into a slightly more detailed category of disorders. So rather than just MSK disorders, it's now identifying low back pain, neck pain, and subcategories of MSK disorders. And I think what's interesting, if you look at the top 10 most burdensome diseases in the West Midlands, and it's broadly similar for any region of the UK, is you've got low back pain is number 1, headache disorders number 4, falls number 5, 6 neck pain, 8 osteoarthritis, and 10 all the other musculoskeletal conditions. So out of the top 10 most burdensome diseases in the country, at least 6 of those are probably going to fall within the remit of the kind of treatment that we might deliver as osteopaths, which I always find quite fascinating. But this is when you look at the cancers, the COPD, the cardiovascular diseases, they feature way down on the list compared to MSK disorders in terms of burdensomeness. So the exclusion criteria that I alluded to earlier, there were quite a lot, and so we have to sort of look at that and think, well, how does that affect how I apply the results of this study to my patients? So they excluded 95 people because they had less than moderate pain interference. So you had to have quite severe pain to qualify for this study. Your pain intensity had to be, over 5 out of 10, I think. So average pain intensity of 0 to 3, they were ruled out. If you had any major surgery planned, you were ruled out. If your back pain wasn't chronic, you were ruled out. So these findings are really only applying to chronic back pain patients. If you've had your back pain less than 3 months, you weren't included in this study. You had to speak English. You couldn't have any medical conditions that prevented you from being physically active, because exercise was a key intervention for this study. You couldn't have sought care recently. This had to be a long-standing condition. You couldn't be pregnant. So you have to sort of think there's quite a few patient groups there that you might see to which this research might not be applicable because those individuals were excluded from the study. So the Rowland-Morris Disability Questionnaire was the questionnaire that they used to assess how limited their participants' activity was to decide on whether the intervention was working or not. So this is essentially 24 statements that the participants read through, and then they tick which ones apply to them, and essentially end up with a score out of 24. And so all these statements relate to the kind of impact that their condition may have on their day-to-day activities. So it's a measure of disability. The EQ5D was used to measure economic outcome. So it was used to assess the financial cost of the interventions and how much money that the interventions could potentially save. It's quite similar in its structure, and it's basically the patients describing the impact that their condition is having on their life by identifying statements that best fit their circumstance. So they choose the statement that most fits their circumstance from each of those categories, as well as giving an overall rating. So that was the 2 main proms that we used, that the patient reported outcome measures that we used in this study to assess the primary outcomes. So going to the introduction, so this is the introduction of the paper. I've just picked out a few things. So the societal costs of chronic pain exceed that of cancer and diabetes combined. So this is just to try and set the scene of impact and the burdensomeness of chronic pain and its importance as a research priority for us to try and identify effective treatments. Chronic pain guidelines recommend physical and psychological factors are addressed. So it's just as critical that we address these psychological issues, which is really what cognitive functional therapy is trying to do. But it does it nicely because it integrates the physical components as well, rather than just being a distinct psychological intervention that is often used. Cognitive behavioral therapy, for example, is purely looking at the psychological factors, but CFT is trying to integrate the physical and the psychological. And it does this by targeting on unhelpful conditions, emotions, and behaviours that are potentially barriers to improvement in the patient's symptoms. So it's particularly looking at provocative movements and nocibic ideas that the patient may hold, particularly biomedical beliefs that the patient may hold about the causes of their back pain. And patients are coached on trying to alter these potentially unusual movement patterns that they've developed because of their pain, the sort of fear avoidance, catastrophization type behaviors, as well as being coached on general health concepts such as adequate sleep, stress management, and starting to re-engage with different components of their life, so exercising, being active and partaking in family activities, etc. So having a look at the methods of the study. So the participants were adults with chronic lower back pain. They had to have a numerical rating score of more than 4 out of 10 for their back pain, otherwise they were excluded. And they had to have moderate pain-related interference with normal activities. This was measured with a slightly different questionnaire, the SF-36, which is essentially a very generalized measure of health status. And they were adaptive random allocation to one of 3 groups. So it was random allocation, but this was controlled for, so that they had similar groups in the 3 arms of the study, rather than it being completely randomized. They tried to keep similar ages, etc., in the 3 arms. Usual care was essentially the people in the usual care arm could choose whatever treatment they wanted. So they would go, this was in Australia, so they would go to their GP, their equivalent of a GP if they wanted. If their GP referred them to a physiotherapist, they would go and have that physiotherapy treatment. If they decided they wanted to go and see a private osteopath or a private physiotherapist or whoever, they could go and pursue that treatment. So it was essentially whatever the patient wanted to do, they could do for the usual care. CFT was delivered on average 7 treatments over 12 weeks, and then they added in a booster session at 26 weeks because previous research had shown that the effects of treatment in chronic pain generally wane over time. So they wanted this booster session because they were monitoring at the 12-month mark, and they wanted to obviously try and ensure that patients were still improved at the 12-month mark. So CFT with biofeedback was they used biofeedback sensors, which were little sticky-on sensors, one on the pelvis, one on T12, and that gave information about movement, speed, direction, etc. So the CFT was essentially conducted in a normal sort of physiotherapist-patient interaction. There'd be a case history, there'd be an examination, but there was a particular focus on interviewing the patient about the movements and postures which triggered their pain-related thoughts they might have, what their thoughts on what tissues were damaged in their back, what was causing their pain, what emotions they attached to their chronic pain, and then discussing things in their lifestyle that are potentially contributing to their pain. So the full sort of psychosocial approach to their pain. There was a big component in terms of validating the patient's concerns, and then exploring what goals they wanted. So what were they looking for long term? The 3 main components to the CFT approach. The first one is making sense about the pain. So exploring the patient's beliefs about tissue damage, because if we're looking at chronic pain past 3 months, we're probably not really looking at tissues as being the main driver of symptoms. That it's likely there's some central sensitization and there are other triggers and drivers for their pain. So it's starting to explore those in more detail, the catastrophization, the fear avoidance, and the triggers that other things might have, such as not getting enough sleep, etc. And then there's an element of graded exposure. So it's about exploring those movements which are known triggers and that might be currently being avoided by the patient, and gradually trying to expose the patients to those movements in safe, controlled ways, gradually to start to demonstrate that those movements can be engaged with, and try and reduce the fear avoidance in the patient, trying to get rid of protective behaviors, things like bracing, abdominal bracing, spinal bracing, and pivoting from the hips, and perhaps trying to get patients to, through a process of relaxation, start to flex their spine when they move, and start to learn that the pain isn't necessarily always going to be there with those movements they've been fearful of in the past, and that would be supplemented with exercises. And then general lifestyle changes, stress management, sleeping more, starting to exercise, and engaging in social engagement. So this is the CFT process. Apologies if you can't read it too clearly. It's obviously in the paper. But firstly, an individual would present with low back pain. They then undertake a triage process with these participants. So 90% would have non-specific low back pain and they'd be clear to go through to take part in the trial. You'd have around 5 to 10% on this left-hand box where they might have a significant neurological deficit. So they'd be referred on for imaging for potential issues such as severe disc prolapse, spinal stenosis, etc. If the neurology improved, they'd then be reintroduced to the trial if possible. And then around 1 to 2% in this box on the right-hand side, you might have some sort of systemic cause of their pain, so a malignancy, infection, fracture, etc. And they'd obviously be triaged for appropriate treatment. So then those that were included in the study, they'd be assessed, as I discussed, for these pathoanatomical, physical, psychological, social, lifestyle, all these related factors. And then something called the start-back screening tool would be used to stratify their risk, as in terms of how complex is their back problem. So if you've not heard of the start-back screening tool, this was something developed at Keele University. It's quite widely used in primary care to essentially determine how complex and difficult a person presenting with chronic back pain is going to be in their management, and it stratifies them as low, medium, or high risk. So in general, low risk individuals will probably have self-limiting symptoms and will resolve through a matter of time. Those in the medium and high risk are more likely to need increasingly complex levels of intervention that address psychosocial factors. So they were grouped in this study into either low risk or medium or high risk, and the medium and high risk individuals were given more treatments, or more treatments were sort of budgeted for those individuals. But the start-back screening tool is a really easy way to a really quick way. There's only 8 questions and then an overall score, number 9, to triage patients' severity. It's been well validated in multiple studies. So once they'd had the start-back applied, they'd either be put into the low disability, low complexity profile, or the moderate to high, where they just get a little bit of extra treatment and potentially specific psychological intervention from a clinical psychologist, as well as the physiotherapist input for the CFT. So the principles of CFT are in this central box. You've got the kind of causes of back pain. So we've got the genetic, epigenetic factors of our, pathoanatomy, psychology, etc., the pain processes. We've also got different stages of life, which may bring different risk factors: childhood, pregnancy, elderly, etc. And then there are system changes, so changes to our nervous system, neurological system, neuroendocrine system, which may precipitate back pain. And then above and below that, you've got sort of the positive and negative influences to all of those things, which we're trying to address with CFT. So at the bottom, these are the things we're trying to identify and then reduce in the patient. So cognitive factors, that's negative beliefs about their back pain, perhaps biomedical beliefs, nocibic beliefs, catastrophizing about their pain, being hypervigilant to their pain, having potentially low self-efficacy or an external locus of control. Emotional factors, stress, fear, anxiety, coping responses, so avoiding movements or bracing when they try to perform movements. Social factors, so avoiding socialization and having stressful issues in their life. Physical factors, not exercising much, and other lifestyle factors, so generally being sedentary, not sleeping, etc. So the CFT aims to try and turn all these potential negative influences into slightly more positive influences, where they're more resilient, they're sleeping better, they've reduced anxiety, they're internalizing the locus of control more by increasing their self-efficacy, starting to engage physically in exercise or socially, and all these things have a positive influence on these causes of back pain. So the movement sensors that they used, these were worn by both the CFT and the non-CFT group, because weirdly in previous studies, they found that when they'd stuck these sensors on patients, even before the patients had received any kind of intervention or before they'd even switched the sensors on, patients were saying, oh, I don't know what you've done, but these sensors are great. My back pain's got loads better. So they realized there was this huge placebo effect with the sensors. So they made sure they stuck them on everybody. They just didn't turn them on for the non-biofeedback group. And they use this information in 3 ways. So they'd use it while they were with the patients to identify painful movement patterns. So they might sort of say, okay, well, you know, when you bend for 30 degrees, you get the pain, and we can tell it's 30 degrees because of that sensor. And then they'd use that to give them feedback. So they might say, okay, well, let's just bend between 0 and 20 degrees because we know that's pain-free. And then we'll use these methods, these breathing techniques, these relaxation techniques, and then we'll perhaps try and bend through 30 degrees. And then at the end, they might say, look, now you're bending to 40 degrees without any pain. So they could give the patients real-time feedback. And then they also sent the patients away with the biofeedback stuck on. And this would actually trigger alerts to their phone to say, you know, you've not moved for half an hour, or you're sitting in a prolonged position or a slouched position, or you've been bending this way, which we know is a trigger for you to try and think about moving differently. So it's sort of a constant reminder for patients. So the results, so the baseline CFT participants had very high levels of disability. So RMDQ of 13.3 on average. The pain was 6.2 out of 10 on average, and they'd had the pain on average for 4 years. This is really chronic. Over half were taking medication, and 93% were medium or high risk on the start back questionnaire. So the proportion of the group with a minimally clinically important difference, which was deemed to be 2 points on the RMDQ, so you had to get more than a 2-point improvement on the RMDQ pre and post intervention. Was usual care. 19% of people with usual care had that clinically important improvement, whereas it was 61% with the CFT and 60% with the CFT with biofeedback. So just looking at it in a little bit more detail, if we look at the CFT and the biofeedback, their baseline scores for the RMDQ was 14 and their pain score was 6.2. After 13 weeks, their RMDQ score had halved and their pain score had come down to 4.4. But what's particularly impressive is even at 12 months, bearing in mind that the intervention stopped after 12 weeks, so they've not had any intervention for 40 weeks, apart from one top-up at 26 weeks, their symptoms are still improving. So after 8 months with no intervention, they're still having reduction in RMDQ and numerical pain score rating, which is pretty unheard of in studies with any kind of long-term follow-up like that. So in terms of being satisfied or very satisfied, in usual care it was 19%. In a CFT and CFT with biofeedback it was up around the 80%. So patients were significantly more satisfied in those groups. So both interventions were more effective. So we've got into some of the statistics a little bit here. So we've got the mean differences, and then the confidence intervals, effect sizes, and that's for activity limitation. Then we've got the same for the economic outcome. So we'll just break that down a little bit at a number needed to treat. So on average, participants' scores on the RMDQ reduced by 4.6 on a scale of 0 to 24. So their RMD questionnaire scores were reducing on average by 4.6. There was a 95% confidence interval of -5.9 to -3.4. What that means is that we can be 95% sure, we're sure that 95% of those participants' score fell within the 5.9 to 3.4 range. So as a point estimate of improvement, it's 4.6, but 95% of the participants would have fallen within 5.9 to 3.4 points of improvement. So that's good. The quality adjusted life year is 1 year of life in perfect health, and this was used to assess the financial benefit over a 12-month period. And so what we can see is that there are significant financial benefits to using CFT. So the direct costs, which were essentially healthcare costs and travel to and from appointments, per participant, there was a saving of $5,000 over a 12-month period. And again, the confidence intervals between 10,000 and 24, but on average, 5,000 is a point estimate. If we look at the productivity losses, so this is patients who are absent from work or patients who are presenting at work but not able to fulfill their job role adequately, then the costs are over $8,000 per participant per 12-month period. So there were significant cost savings to be had for using CFT. And it was calculated that you need to see 2 patients or 2.4 patients with CFT to get that clinically important difference. So every 2 patients you saw, 1 patient was getting that clinically important difference. And that's quite a high, or that's quite a good numbers needed to treat value, 2.4. So just conscious I'm running out of time a little bit, so I'll just go through these quickly. So at baseline, participants had high levels of disability. The 2 intervention groups, the median number of consultations was 7. And then the power calculation was 80% power. So what the RMD score means is that the standard deviation was 5.2. So that means that 1 standard deviation, which is the green area, which is about 68% of the sample, their score will have been 5.2 points above or below 13.5. So we can see that the majority of participants' scores would have been 5.2 above or below 13.5 points improvement. That's what that standard deviation is telling us. The interquartile range is the spread of results. It's the middle half of the spread of results. So half of the participants would have had between 4 and 8 treatments. So not a lot really in terms of people having back pain for 4 years, and then they're having 4 to 8 treatments and they're seeing significant improvement. The minimally important clinical difference was that if you were to compare between the groups of individuals, they had to have an average of 2 points improvement. If you were to look at an individual, they had to have 5 points improvement on the RMDQ. The p-value essentially means that there's less than a 5% chance that the null hypothesis is correct. So, that's the sort of error, if you like. And the power is an 80% power, which means it's an 80% chance of ending up with a p-value of less than 5 if there really was an important difference between treatments. So again, it's all about the probability of how believable or how true these actual statistics are. So it was a well-powered study. So quickly on the discussion, so the clinical effectiveness of CFT was larger than pretty much any intervention has been demonstrated for chronic low back pain previously. However, CFT does require longer consultation times than normal physiotherapy. It's been estimated that would cost about 7% more to deliver that physiotherapy. But when you look at the cost savings per participant, it's still good value. CFT targets well-known factors and predictors of low back pain, such as self-efficacy, self-management, catastrophization, and fear avoidance. So it's evidence-based treatment. The clinicians did receive a lot of training, much more than is usual for an RCT. Each physiotherapist had about 100 hours of training. That's quite significant extra training for a professional, so we need to take that into account. They had this 6-month booster session, so that probably helped the 1-year follow-up scores that we saw. But most of the treatment was finished within 12 weeks. It was just the 1 booster session they had at 6 months. It was conducted in primary care clinics, so similar to how we would see patients rather than a specialist hospital setting. The amount of care in the usual care group was not controlled, so we don't really know what was happening. They could have been having anything really, or nothing. It wasn't matched in any way or restricted. Patients were free to access whatever care they wanted. So if you're interested, they've got the paper's free to access. They've got a nice infographic. They've got a website which goes into a lot of detail, provides a lot of extra resources. There's also a Physio Matters podcast where Peter O'Sullivan and Peter Kent, 2 of the authors, talk about their study and go into quite a lot of detail, which is good as well. So it's an interesting study, and I think we do a lot of what they covered in osteopathy anyway. It's just that this was CFT just structures it in a nice way, but I think we already do a lot of what's covered in CFT. So I think it's useful to look at and just sort of say, well, I do that, but I could perhaps include that a little bit more, and that might be useful to add to my practice. So I think it's a worthwhile study to have a look at. Thank you.